Okay, Dr. May.
Good day, everyone, and welcome to our panel session on COVID-19 pandemic and impacts to colorectal cancer screening. My name is Fola May. I'm a gastroenterologist and colon cancer researcher at UCLA and in the VA. I'm honored to be the moderator for this session today. We have an incredible group of experts representing different perspectives of the impact of COVID-19 on colorectal cancer. I'll provide a short introduction and then we will get started. Next slide, please. COVID-19 has impacted almost every aspect of human life over the last 9 months. The focus of our gathering this week in CRC, in which we have seen also a massive impact of this pandemic. COVID has impacted screening and early detection for colorectal cancer, advocacy and community engagement, research, and also cancer care. And in this session, we will explore how the pandemic affects colorectal cancer screening at different intersections of the healthcare system. Next slide, please. On March 14th, 2020, the US Surgeon General advised that all hospitals cancel non-urgent elective surgeries and procedures. In March and April, gastroenterology professional societies released joint society guidance for endoscopic procedures during the COVID-19 pandemic. Though these actions were necessary for COVID-19 containment and mitigation strategies, the impact on CRC efforts has been profound. Next slide, please. These data represent quantitative population health data analysis and survey results from April and May of 2020, conducted by Fight CRC and Komodo Health. Colonoscopy rates were stable in the United States for the first 11 weeks of 2020, prior to the first shelter-in-place orders that began in California around March 19th. As you can see, during the week of March 16th to 22nd, colonoscopy utilization fell by about 42%. And by April 12th, colonoscopy utilization had dropped by 89%. In line with declines in screening and colonoscopy use, we also saw declines in biopsy rates, which declined by also about 89% by mid-April. Next slide, please. There was also a notable decrease in colorectal cancer diagnoses at the same time. Though not as pronounced as what we saw with colonoscopy utilization, new colon cancer diagnoses were down by more than 32% by mid-April. Next slide, please. Somewhat more surprisingly, we also saw a decrease in utilization of colorectal cancer surgeries. Now we think that some of this decline in treatment is explained by the drop in diagnoses, but it's such a large step down that it probably also means that people who were newly diagnosed with colon and rectal cancer in the preceding months may have been postponing their surgeries, which is of concern. Overall, we are very concerned that many of these policies, including shelter in place that was necessary, as it has continued in many parts of the country, will lead to worsening colorectal cancer outcomes for many patients. Next slide. This analysis shown here shows the excess mortality plotted by year, and suggests that we will see roughly 10,000 excess breast and colorectal cancer deaths over the next 10 years. This represents a roughly 1% excess in deaths from these two major tumor types over that period of time. For both of these cancer types, we believe that the pandemic will influence cancer deaths for at least 1 decade. Next slide, please. With that, I'd like to briefly introduce our 4 panelists, each of whom will speak for about 5 minutes before we open for Q&A. And I encourage you all to jot down any questions that you have in the Q&A, and we'll hopefully get through all of those. Although I wish I could give a full introduction for all of these extraordinarily panelists today, I'll provide just a brief introduction, and their full bios are available on the CVET website. Our first speaker will be Dr. Mark Pachapin, immediate past president of the American College of Gastroenterology and Gastroenterology Division Director at NYU Langone Health. Then we will hear from Dr. Carmen Guerra, Vice Chair of Diversity and Inclusion in the Department of Medicine, and Associate Director for the Office of Diversity, Abramson Cancer Center at the University of Pennsylvania. Third, we will have Dr. Cheryl Mudaka, who is the Director, Quality Center, National Association of Community Health Centers. And our final speaker is Dr. Jay Bott, Principal at JDB Strategies LCC and former SVP and Chief Medical Officer for the American Hospital Association. Dr. Pachapin?
Thank you, Fola, and thank you all to the organizers of the roundtable meeting. It's probably the first time I've ever given a presentation in my scrubs at a roundtable meeting, but we're all busy, but we're together virtually, and I think it's so important to talk about this critically important topic. And I was actually doing procedures all morning, and half of those procedures were actually screening CRC procedures. So in New York City, we are getting back to screening with colonoscopy. Oh, next slide, please. So I want to just put some high-level concepts out for everybody. The first is, what is the national perspective and the high-level ideas of the COVID impact and the considerations? And so what do we need to focus on? Well, one, availability of testing. And we have to recognize that for all of the things we're going to discuss, it is very regional. That availability of testing in New York City is very different in the middle of Wyoming. So one, what is availability of testing? Two, do we need to test patients prior to having endoscopic procedures like a screening colonoscopy? Three, what is the community prevalence of COVID positivity? This is critically important because we have to split between high prevalence and low prevalence. And what's the availability of PPE for the medical staff and all the people who work with the medical staff, like the advanced practice providers, the nurse practitioners and the PAs, the nurses, and the physician extenders. Next. And what are the most pressing challenges and obstacles? There are three of them. One is at the patient level, that the patients are still frightened to come to a healthcare facility, thinking that's a place where people come with COVID and that they may be putting themselves at increased risk. And as Fola showed, we had a dramatic drop off, not only of screening procedures, but people weren't coming in with strokes or heart attacks or any of the urgent conditions that required them to come to even the ER. And again, availability of COVID testing and availability of PPE. Next slide. So how do we overcome these challenges? Well, first, we do need to recognize what the community prevalence is and split it between high prevalence and low prevalence. If a place is high prevalence and the numbers are going up, that's where stool testing become very valuable, recognizing that if a stool test is positive, say a FIT positive test, that patient still would require a colonoscopy for follow-up because obviously we have to follow up these positive exams. Now, a low prevalence, we could do screening as usual, meaning you could do, whether it's a stool-based test or the colonoscopy-based test, both are acceptable and both should be accessible and safe. We need to educate on the safety of colonoscopy for any prevalence because, as Fola mentioned, people even with cancer weren't coming in, whether it's for their colonoscopy or for their surgery. And the truth is that now we understand how to distance, how to test, how to wear PPE, and how to keep patients safe in any healthcare environment, including when there's a high prevalence. And we have to get the message back to where we've always been. The best test is the one that gets done. And in this case, we need to get the test done in the first place and not be afraid because of the pandemic. Next slide. This is a testing and PPE decision tree that the ACG put out back in April, and it still holds very true. And I just want to quickly mention it because I think it will be helpful for a discussion. Again, it really depends on low prevalence and high prevalence and testing ability and access. So not every place can get a test. In fact, I was telling Fola earlier that I passed a city MD here in New York City, and there's a line around the corner now for testing for COVID because people are getting concerned. So if in the low prevalence area, if we have a low prevalence and we have a negative test, then that patient can come in for their screening colonoscopy and actually standard precautions. We don't even need to wear N95 as the physician's caring for the patients, although most of us still do. If it's low prevalence and you don't have the testing available, then you always assume the worst case scenario. We should wear N95s of healthcare providers and treat patients like they might potentially have been exposed or have COVID. High prevalence is really different. Whether the test is positive or not, those patients really need to be treat it as if they could have COVID. Everyone in the room caring for the patients needs to have N95s. And if they actually test COVID positive in a high prevalence area, that's when you have to have a specific area dedicated for caring for COVID patients. So the point really comes down to prevalence and availability of testing. We could talk a little bit more about this in discussion. Thank you very much.
Thank you very much, Dr. Pachepen. And Dr. Guerra?
Good afternoon. Thank you, Dr. May, for the opportunity to be part of this esteemed panel session. And thank you to all of you for sharing your valuable time with us today. My perspective is that of a primary care physician. And so I'd like to advance to the next slide and give you the perspective of what it's been like to be a PCP who really deeply cares about colorectal cancer screening, as I have spent my entire career on, and talk to you about the challenges that we had. And our challenges were trifold. They had to do with first disruptions in the primary care workforce. Secondary, as you heard from both of the previous speakers, Dr. May and Dr. Pachepen, we had problems with our patients being able to access their primary care physician and patient fears. And then we, of course, had the limitations of cancellations of elective procedures. So those were the three major challenges, and I'll speak a little bit more about each one. With respect to the primary care physician workforce disruptions, many of us were pulled to cover COVID-19 wards during the height of the pandemic. And so we lost a great proportion of our workforce, especially considering that most of the primary care physicians are either boarded in internal medicine or family medicine, and they therefore are in best positions to be hospitalists and care for the newly hospitalized patients. Our nurse practitioners were also pulled to cover influenza-like illness tents for COVID testings. And then we had physician physical distancing, provider physical distancing, new policies that made our office not capable of handling the usual number of primary care physicians. And then, of course, we had our own PPE challenges as well. From the patient perspective, we heard about patient fears and concerns, and those are still very prevalent. But we also were dealing with stay-at-home work orders that the state had issued. And then many of our patients actually lost their jobs, and they had subsequently a loss of health insurance. And then as the health systems began to quickly adopt telemedicine visits, we learned that many of our patients didn't have the capacity to access our providers because they lacked access to broadband. In Philadelphia, shockingly, 26% of the population in Philadelphia does not have access to broadband, according to the most recent US Census. So all of that threatened the ability of patients to access us. And as you can see in the middle photo here, our offices became very empty. And that resulted in a 50 to 60% reduction in patient volumes in primary care physicians' offices, which actually disproportionately affected older and lower socioeconomic status patients. And next slide, please. And so how we began to overcome these challenges in primary care was actually to go back to adopting what was an older strategy that many of us had used before colonoscopy became so freely available to many of us, which is a FIT-based colorectal cancer screening strategy. We recognize that a FIT-based strategy overcomes many of the COVID-19 challenges, including that it does not require an office visit, and therefore overcomes the workforce disruptions and many of the patient concerns. It also further risk stratifies individuals who need to be prioritized for the colonoscopy, and then we can use the very precious colonoscopy suite time accordingly. And furthermore, there's a lower cost to FIT screening compared to colonoscopy, which of course, given the economic concerns throughout the country, was also an important strategy. And then the last benefit of a FIT-based strategy was that we could actually run the FIT-based kits in our office, and thereby reducing further burden on our lab colleagues, lab and path medicine, who were so busy trying to identify the resources to be able to do COVID testing on site, collecting the supplies and being able to turn over the COVID-19 test results. And so we could unburden them by running these tests in our office. Next slide, please. And an innovation came after us beginning to readopt the FIT-based testing, colorectal cancer screening testing, which was that we recognized we were doing drive-by flu vaccines. And so what we began to do was, thanks to our dear friend Michael Potter, who had published about 10 years ago the original flu fit strategy, we actually adopted it to be able to offer this in the community during the drive-by flu season shots, and added a fit line to our patients who were coming to us. And how we did this was we worked with a large church that serves the underserved and the Black community in Philadelphia, church that serves about 16,000 members. And our team went out and did the drive-by flu fit. And in this pilot that just took place about 2 weeks ago, we gave out 150 kits. We've already in 2 weeks gotten 73 completed fit tests back. And we have a positivity rate of about 12%. So this was just one small innovation that we began to been successful, and that we look forward to continuing to disseminate and implement in the community. Thank you for your attention.
Thank you very much, Dr. Guerra. We already have some questions coming in. I want to remind everyone that if you have questions for our panelists, please go ahead and put those into the question area, and we'll get to them after our next two speakers. Now we'll have Dr. Modica speak, please.
Great, thank you, Dr. May. And again, thank you to the Colorectal Roundtable for the invitation today. Again, you can see here, my name is Cheryl Modica, Director of the Quality Center with NAC, and NAC stands for the National Association of Community Health Centers. And for those of you who may not be familiar with who NAC is, we represent community and migrant health centers across the country. And those a very vast network of organizations that serve the medically underserved across our country. And so they're located in about 13,000 sites, 1,300 organizations serving 13,000 sites, everywhere from rural, urban, and all in between. So with the lens that I'll take in the next few minutes will be looking at sort of a health center response to colorectal cancer screening in this time of COVID, and some work that the National Association of Community Health Centers is doing. So next slide, please. As we approached this, the thinking about grappling with, and we too experienced much of what the previous presenter shared. So depending on where our health centers were located, whether they were the New York and at the early edge of the pandemic, or some of our health centers now in the Dakotas or other areas, Midwest and elsewhere, that are having some significant spikes now. So again, it's really been varied over the course of the last 7 to 8 months in terms of where health centers have been, but all have recognized that they need to have a strategy for addressing not only colorectal cancer screening, but as you can see from this slide, we very much approach it from a systems approach, meaning that with limited resources and primary care teams that are focused on really whole person health, we have been coming at the approach through thinking that in this time of COVID, how do we engage patients in this new virtual realm, not only around colorectal cancer screening, but other really critical conditions, things like diabetes, hypertension, obesity, some of the depression and substance use we're seeing increase in this time of COVID. And recognizing that things like diabetes, hypertension, et cetera, that the data is showing that those who have those conditions often have greater severity of COVID illness. And so one of the ways that we've been looking at this is through what we call a value transformation framework. Again, this pre-existed before COVID, and was really, we were able to execute it and move forward in a very impactful way during the pandemic, and continue to do so. And essentially looking at what you see on your screen are the three what we call buckets or domains of infrastructure, care delivery, and people. And essentially those are parts of a healthcare system. And what we do is we help guide the health center in thinking about what parts of infrastructure need to be managed or adjusted or changed, and what does the evidence say in those areas. Likewise, in care delivery, what is the evidence saying around colorectal cancer screening and other areas, and then also in people's systems. So next slide. So as we thought about ways to be able to tackle the decrease we were seeing in colorectal cancer screening, we were considering this idea that, again, care was moving to the home. Health centers were doing much more virtual. In many cases, again, the data mirrored what a previous presenter shared, where in-person visits dropped off sometimes 60 or 70% initially, and went to a virtual realm. That's gradually been going back in many parts of the country to in-person care, but but virtual care is not going away. And so really where the National Association has come in together with a network of health centers across the country. And before I move to the next slide, I'll preface it by saying that one of the projects that we do, it's called the Elevate Learning Forum, and it engages about 1/3 of our health centers around the country in applying this systems approach. So thinking about infrastructure and care delivery and people and evidence-based interventions in each of those areas, and kind of applying those evidence-based interventions to tackle things, again, like colorectal cancer screening, et cetera. And so from within that larger cohort of, right now it's 426 health centers that are working on application of the value transformation framework, we just launched a pilot project. And so the next slide, we'll talk a little bit about that. And we're starting with a small cohort that we eventually anticipate, we hope, ramping up on a much wider scale nationwide. And that is to, with this idea of transforming at-home care. And the way that this pilot project is working is we had a competitive application process from health centers across the country. From that pool of applicants, and we had about 3 times as many applicants as we could accept. So again, lots of interest from the field. We picked 20 health centers and provided them with what we call patient care kits. So related to colorectal cancer screening tests, and similar to the last presenter, we included a FIT test in that care kit. But very importantly, we didn't just give a FIT test, we also package that together with home blood pressure monitors, with home A1C tests, weight scale. So we included scale, thermometer, critically important in the time of COVID. And again, for many of our patients, they may not even own a thermometer at home to be able to monitor temperature, and a tape measure. So what that means is through this care kit, the health centers oftentimes deliver the package to their home. In some scenarios, they have drive-by clinics, maybe something along the lines of the flu fit or a fit test or other rapid testing around COVID. And it's in those drive-bys that patients may pick it up. And then in a few cases, some health centers schedule the first visit where a patient comes in for instruction. But in all cases, it is the team providing instruction, again, either visually through a virtual visit, or in some cases drive-by or in person, and providing this test. And we're just now launching. They're having the baseline visits this month, so a number have already been completed. And what we're finding is very positive receptivity among the patients to this whole person approach, to a package or a suite of tools and kits and supplies that they can use in their home. And then very importantly, in the case of colorectal cancer screening, some very aggressive follow-up. So after the first baseline visit, we call it, then they're collecting some data. Then the care team is following up with this cohort of patients within the first 1 to 2 weeks and asking if they've completed the test, if they've had any questions. Again, they've already provided the instruction they need to be able to do that kit at home, but then doing the outreach and follow-up to ensure that kit gets back to the health center. And again, they have a variety of ways in which it's getting back. We are not using a mailed system based upon both what some of the literature has showed with some of the difficulties in that, and what our own health center experience has showed with mailings, et cetera. So in some cases, they're being picked up. In some cases, patients are dropping them by the health center. And again, in other cases, it's a drive-by scenario. And so the last slide just gives you a sense or a visual. So if you could move to the next slide, shows what's in that care kit. So again, I said those out loud. In addition, we provide very brief one-page instructional materials, kind of front and back, for the patient, written at a 5th grade reading level, that speak to FIT testing or A1C testing or home blood pressure monitoring. We also provide them logs. Again, they're getting education and instruction on how to complete those logs, and we're translating those to multiple languages. We have about 3 or 4 languages that we've made those tools available in. And so we see this as an important way in the current COVID era, and with the cases that are continuing, we anticipate that even those health centers that may have moved to more in-person screening, that could swing back to more virtual care. And so through this national pilot, we're trying to develop workflows, policies, protocols, templates that could be shared with health centers nationally, and certainly be applicable to primary care practices across the country as well. So with that, I'll end my presentation and happy to answer questions later. Thank you.
Thank you very much. Our final speaker before we move to Q&A is Dr. Bott, please. Thank you.
Thank you, Dr. May, and thank you to the American Cancer Society and the National Colorectal Cancer Roundtable. Appreciate your leadership and the leadership of Dr. Dorado Brooks on this issue, and appreciate the leadership of those on this panel. Now, I'd like to start with the next slide, state of play. Hospitals and health systems play a critical role in community screening, reducing late-stage cancer that shows up on their doorstep, and facilitating professional development and education. The figure on the left is from a BCBS Health America report illustrating uptake of different screening modalities. Now, if we were using other screening modalities more effectively or at higher levels, would we see colonoscopies as a smaller percentage of that total? Could be useful looking at that data in your own organization. Now, on the right is a figure demonstrating the progression of screening after Kaiser implemented a systemic approach. And you see FIT tests rising and also more screening up to date. Now, the previous speakers have alluded to some of the challenges currently with respect to colorectal cancer screening, and elective procedures being curtailed is a concern, and hospitals and health systems see this as an issue and have adapted over the pandemic. And now a concern again, given rising rates across the country of COVID-19, and protocols for pre-op testing continue to evolve and have variation, but are critically important to be consistent with current guidelines. So we keep people safe and are moving forward appropriate care. Many systems struggle with the screening part of the care pathway, as well as return rates of fecal occult blood tests or FIT testing, and long wait times or faulty screening, misstaging, and suboptimal treatment decisions are some of the challenges we see. Next slide, please. Challenges and barriers occur at the individual, patient, provider, system, community, and national levels. For the individual, knowledge, awareness, beliefs, and stigma, prioritization, among other obligations and responsibilities, are critical. Access to both insurance and what they have to manage in the midst of their life. On the provider level, one of the issues is lack of recommendation. The number one predictor that someone will be screened is that their provider recommended it. Lack of recommending choices for screening. Data demonstrates there's greater uptake when patients are offered choice as opposed to just one test option. And then the system, lack of an integrated model. We see that integrated models can improve screening, decrease cancer incidence, decrease cancer mortality. And there aren't systemic processes and reminders to ensure patients are contacted and connected with follow-up that is at higher levels. And that issue also becomes an issue with lack of insurance coverage, and particularly for colonoscopy after an abnormal stool-based test. Now, Dr. Zeruni and colleagues from Brigham and Women's Hospital in Boston sought to answer the question related to Medicaid, and you'll see the upper left data showing that by using health-related telephone surveys administered by the CDC every 2 years through the behavioral risk factor surveillance system, you could ask questions regarding preventive cancer screening, basically suggesting that in this study, Medicaid expansion as a result of the Affordable Care Act was associated with increased rate of colorectal cancer screening. I don't know that we have great data about what is happening necessarily with those patients during COVID-19. You know, are we seeing increased uptake with those? But it's still a challenge, particularly because of COVID hitting disproportionately among people of color. The other on the right of that is the issue with the unemployed. Many that will be unemployed may not have coverage, may not have been able to participate in open enrollment and the exchange. Could unemployment offices and other places where you can meet patients where they're at be an opportunity to educate around colorectal cancer prevention, and follow-up being a challenge. The other is data fragmentation and the challenges with getting the right data in the right hands to make the decisions at the right point in time for patients and their families. And then social determinants of health and systemic issues. One hard to reach patient population, the homeless, can't access a screening service. In-person colonoscopies require a visit to an off-site GI clinic and the use of a sedative. After the procedure, patients require a companion and reliable transportation to ensure that they get home safely while sedative effects wear off. Now, these are not options available to homeless patients, as you've got to think creatively about that population. Next slide, please. This is a slide showing the NCI designated cancer centers. 51 of the 71 are comprehensive care centers located in 36 states in the District of Columbia, supported by the National Cancer Institute. And most of them are affiliated with university medical centers, although several are freestanding institutions that engage only in cancer research. Now, can hospitals lead promotion and navigation of colorectal cancer screening continuum in partnership with primary care and community-based partners? Could we tap into these designated comprehensive cancer centers to better prioritize colorectal cancer screening? Think on discharge, during their stay, during an ED visit, flagging high risk, especially an average risk thereafter, perhaps automated on paperwork or using ADT codes that the admission discharge transfer codes that deliver real-time data to the primary care setting or the medical home. The other issue on the left is one that I worked on with the American Hospital Association called the Hospital Community Cooperative. And there we try to understand, how do you partner with community? That is a challenge. Hospitals and health systems, some are much better at it than others, but you're at most places are at different places in that continuum. So what's the roadmap, and how do we help community partnerships be meaningful and sustainable? And we need partnership with all community stakeholders using co-design in the language of that community. Next slide, please. Now, the other thing we can consider and think about is mobile technology as one approach. Empath is an example where on an iPad in primary care provider offices before a medical visit with a patient-friendly self-survey interface, you can assess patient need for screening and then get education and allow patients to self-order a colon cancer test. And Wake Forest and others have studied this and saw that in a group of 223 patients assigned to Empath, 30% completed a screening test within the study's 24-week follow-up period, compared with 15% of the 227 people in the control group. So, there's role for digital and app and even voice. So you see Alexa, potentially providing reminders and action-oriented messages to patients. The other is in the flat polyp commonly missed by endoscopists, figure the idea of artificial intelligence and machine learning. A study published in 2012 in endoscopy noted that 25% of polyps can be missed during colonoscopy. We've gotten much better at that, but there's a lot of discussion about computer-aided polyp detection systems using deep learning and shown to increase the ability of endoscopists to detect polyps and provide further intelligence. The other is a systemic approach. There are use of cancer pathways and optimizing them. The other is engaging your frontline teams, medical assistants, receptionists, those that are registering, checking in patients to be advocates and sign up folks for colorectal cancer screening. So with that, you see on the right, there's just a number of places you can go for increased cancer screening. And with that, I'll just transition and look forward to the Q&A. Thanks so much.
Thank you very much for that wonderful presentation. Thank you to all of our panelists for your incredible presentations and for participating. We have so many questions, and my hope right now is that we'll be able to get through as many of them as possible. I'm going to ask all of our panelists to put their cameras on, and let's see what we can do here. So the first question, and to our audience, keep posting them. Also, I think you have the opportunity to upvote questions, so let us know what you want to hear about. So the first question is for Dr. Pachapin. Any published data on risk of patients getting COVID during colonoscopy visits? Many of my patients are refusing to go in due to fear of getting COVID at the health facility. I usually tell them it's less than buying groceries. Is that evidence-based?
So it's a great question. We've seen some abstracts. I don't know if there's anything published, and Foley, you may know if there's actually something in the literature. What we do know a few things. One, that actually the acquisition of healthcare workers, and in particular in Italy, Ali Rapisi published a number of articles showing the very low acquisition incidence of endoscopists and staff within the endoscopy suite getting COVID in general during the height of the pandemic in Italy. So we think it's actually a very low possibility of transmission. And we haven't heard, I've actually polled my colleagues in New York, we haven't heard of one patient getting, not a single one getting COVID, even during the height of the pandemic. And now that we're screening, we're doing testing before all patients come in to the New York sites. And I can tell you that's incredibly low also, because we do all the contact tracing and questions beforehand. So I think it's very low. I actually am not concerned at all. If a family member or myself needed a screening procedure, I wouldn't think twice about it. I'm not concerned.
So we'll stick with less than buying groceries.
Yeah, that's for sure.
Great. The next question, the NCCRT, and this is for, I think, any of our panelists who want to answer. The NCCRT is advising starting screening for colorectal cancer at age 45 based on modeling studies. Question number 1, is modeling evidence enough for us to recommend screening at age 45? Second part of the question, the US current financial crisis should make us consider costs of tests. So that's more of a statement. Anyone want to take this one?
You know, it's Jay. I would say that it's an important question, and I think we think about this in the context of the holistic story of what the risks are, what the benefits are, what's going on in the context of the patient and their family history, and then move forward. I think that we know for people of color and disproportionate populations that it is critical to get them screened early and appropriately. And so I think that's where we can focus and get support for that from a reimbursement perspective.
And Fola, I think we only have modeling data right now for 45 and over for screening. We're talking about healthy individuals with no family history, no high risk. And actually, as you know, because we've talked about this, but the U.S. Preventive Services Task Force has a draft out now where they're recommending screening from age 45 to 50 as a B level class recommendation, where 50 and over has always had an A classification of U.S. Preventive Services Task Force recommendation. So actually, it's very possible that once and I saw another question in here about coverage for 45, once the United States Preventive Services Task Force says 45 and B would be covered by Medicare and Medicaid, then all the private insurers will follow. So I do think 45 is probably coming. How that's going to map out, there was actually a really nice review by a bunch of folks who looked at the concerns that will we increase disparities if we start moving towards a better insured group of 45 and over, utilizing the limited resources we have for screening. And Fola May is actually an expert in that area. And Fola, you might want to comment on that.
I mean, I agree with you completely. I think that we have to think about the implications of any changes like this. I do think that we'll catch more people who are unfortunately getting this disease between the ages of 45 and 49. I do worry about worsening disparities in the older population. Modeling data is all that we have, but USPFTF has never been able to consider cost. And there are pros and cons to that, but we certainly, if we're going to achieve this goal as a nation, we'll need many more resources and better policies to make sure we can do that. I agree completely. Okay, I'm going to go on to the next question. The next question is not directed to any particular panelist, so please chime in. FIT that are positive have to be followed by colonoscopy, but patients may struggle to come for follow-up or may not complete colonoscopy after FIT because they think they are screened. FIT has to be returned, but we see low return rates at many sites. So I think these are several comments about concerns about a FIT-based screening program. Any comments on those topics?
Maybe I'll jump in and say from the health center perspective and some of the work we're doing that I mentioned with the patient care kits is really nesting it in this more whole person approach. And oftentimes it is a community health worker, a navigator, a care manager, individual who's working with that patient, not only to ensure that if they got the FIT test, again, even if it's not a part of this patient care kit pilot, but in that case, there's some pretty aggressive follow-up on a regular basis. But even if they received a test, say, in the, through a health center visit outside of this pilot project, it's been the experience of the health centers that have these additional, again, health workers and folks who are following up, where we see the greatest return. But it certainly is a concern. And one of the reasons for our particular pilot project that we also decided not to go with the mailed route, because we've had a number of health centers in some various projects that had tried the route of providing FIT tests in the home, but then weren't getting them back in the mailed scenario. So that's one piece. And then just the last thing I'd say is coupling that with education. So not only the follow-up and outreach and navigation piece, but education. So patients realize that if there's a positive fit, that they understand that what's next and the implications that are guided through that.
Absolutely. Another area where I think we need more awareness and more policy, right? Because those patients are not screened. Any other?
Yeah. If I could, I'd just address the comment about speaking with patients with positive FIT who might think they already were screened. I actually haven't encountered that. In fact, it's the opposite. When you tell somebody that there might be something wrong because they have a positive FIT, they are more likely to want to know if there is something wrong and continue to have that colonoscopy. And with regards to the question about FIT having to be an annual test, yes, absolutely, that's a drawback. And that's why, most physicians opt for the colonoscopy, most primary care physicians like I do. But coupling it with the annual flu vaccine, where we're used to coming in for that annual flu vaccine, coupling it with that already provides that infrastructure that you need so that you can complete the screening program of yearly FIT tests. Thank you.
There's so many questions to choose from, but the next, I'm sorry, Dr. Pacheco.
No, I'm just going to say that, again, the education is key, that colonoscopy is safe. And when we were at the height of this thing, we were putting positive FIT testing as a delay of a few weeks, but it was no longer screening. The worst stat I've ever seen is actually somewhere between 20 to 40% of patients FIT positive don't get followed up. That is a crime. I mean, it's bad enough if someone doesn't get screened, get them screened and have them positive, because FIT has a pretty high specificity. It's up where in the low 90s. And so we really have to recognize that when we do FIT testing, that patients have to be educated. This is no longer screening if it's positive. This is now a critically important diagnostic component.
Absolutely. Thank you. The next question I'm going to go to is actually for Dr. Bhatt. Patients are more likely to get tested when given choices. What can be done for providers to consistently tell patients about all, capital letters, screening tests? What about CT colonography benefits during the pandemic? Potentially less PPE, no sedation, less contact. You want to comment on that?
Sure. I think that offering all choices so that the patient understands is important, but then offering your perspective, given all the different parts of the story, is important as well. And I think that, it's involving the whole team. So I work a lot with the medical assistant and the nursing staff and the front desk staff, who we, often celebrate if they help appropriately sign up someone that should be getting screened. And I think it's a team effort. And then I would say on the CT colonography, there are pros and cons. And the relationship between endoscopy and radiology is critically important. And as Dr. Pacheco said, there are really safe ways to do colonoscopy, and CT colonography could be useful for some populations, but I think for the high risk and those that are disproportionately affected with colon cancer, we may miss certain polyps or high risk situations, and we can't biopsy during that time either. So, I think again, you have to look at the story and make the best decision, and try to do shared decision making with our patients in the best way possible.
Anybody else want to comment on choice and screening modalities? Okay, I'm going to move on to the next question because we have so many great questions. This one is actually for Dr. Pachapin. A few people have asked, what threshold do you use to identify a low versus high prevalence community? Going back to your slide where you discuss different strategies to improve safetiness of the colonoscopy.
You guys are smart. You realize I didn't put a number because actually prevalence is really defined by the community. And, originally during March and April, New York prevalence of positive testing was over 60%. It was a crazy number. But now I think by and large, we use 5% as about a cutoff. Anything that's 2% or lower is really low prevalence. Once we start getting to above 3 to 5% is middle, and above 5%, we're thinking of higher prevalence because there's much more testing. So I think that's a good cutoff. The AGA actually uses prevalence in asymptomatic patients, which is a much harder number to come by. They have a really cool formula to go through that might help you using data that's available in the community. But I think 5% would be a good cutoff to start trying to break that down and look at your local prevalence as whether it's being considered high or low, and if the numbers are going up.
And the one follow-up question that came from the same attendee, should pre-procedure COVID testing, rapid day of procedure tests, be done on all endoscopy patients or just EGD and bronchs?
Mm-hmm. So that is a great question that we're all debating. Originally, in areas that had been high prevalence, we were testing everybody, and we're still testing in New York, everybody for all procedures. There was a lot of debate whether an endoscopy, an upper endoscopy, is considered a super spreading, aerosolizing event versus colonoscopy, which is thought to be less. But in the end, all endoscopy is lumped together as being something that potentially could aerosolize and spread. I think we're moving away from testing before endoscopic procedures, again, in areas that have low prevalence. But once you get in that middle or high prevalence, I think we're going to start seeing it again. We don't have a great answer for that, but I do think that we can get away, given the availability of testing, of moving away from pre-procedure testing in areas that are low.
Fantastic, thank you. Next question is for Dr. Modica. And I think this is specific to the program that you described. Who manages the FIT test in the kits?
Great question. So each of the health centers, so NAC, and this is an unusual position because we don't usually involved in any actual equipment, supplies, tests, et cetera. And so through our federal partners, CDC is a partial funder, and HRSA, under Health and Human Services, is another partial funder. We were able to purchase these kits. And so we distribute the set of 20 to the 20 health centers. And then there is a lead individual. It's typically, it varies by health center. Sometimes it's the medical director, sometimes, working together with a team of nurses, sometimes it's the nursing director, but there is a lead individual who is responsible overall for the kits themselves. And then, as I said earlier, there's usually a team lead who's working one-on-one with the patient. And it's, again, care manager, navigator, community health worker, and it's that individual who's responsible for getting the kit into the hands. So in case of FIT test, the FIT into the hands of the patients, providing education, follow-up, et cetera. The initial baseline visit is typically done in consultation or as part of the primary care visit, so has a provider component. So a provider is also doing education, reinforcement, et cetera. And then there's more of a care team member or lay approach in terms of follow-up. So the management is certainly a team effort, initially provider-driven on through the team, and then follow-up by members of the care team. Hopefully that answered the question.
And there was one other related one that I'm going to sneak in.
Okay.
How will the results of your pilot be shared, and how can they find out what sites are currently working on this?
Yeah, so a couple things neat about that. Again, everything, even when we do a smaller scale pilot such as this, we try to, as quickly as possible, make information as appropriate available on the national level. So one thing that's available now on our website as we speak is just a brief flyer about the project itself and who the sites are. So if that's of interest, you can go to NAC's website, nac.org, www.nac.org, and you can see that flyer that tells a little bit more about the project and who the sites are. And then we are in the midst of sort of backing up some of the material to make it applicable to any health center across the country. And frankly, again, probably any, hopefully most primary care practices. So we have two kind of toolkits that we've developed. One is a sort of getting ready to launch kit. That's all about training staff, communicating the initiative, developing workflows, logs, etc. And then we have an actual launch guide. So we think that those two manuals or toolkits will be immensely helpful to folks who are interested in doing a project like this. And so we're using our first 3 months or so of our pilot now to refine it, make sure we have it quote unquote as right as possible. And then we'll be posting those on NAC's website beginning in the new year. So about January of 2021. So if that's of interest, we'll all of those tools and resources, as well as the patient educational materials, will be there. And then that would also be, we have a section of the website that will talk about and follow the project. So as we're learning and getting more data, then making it available on that website as well.
Perfect. Thank you very much.
Yeah.
I believe this question is for Dr. Guerra, but I think anyone can answer. What is the compliance rate with flu fit? What % of patients getting their flu shot do return the fit sample? In addition to modeling, oh, actually, that's another question. So let's stop there with those two related to flu fit.
Well, the best rates that I've seen, I believe, are from Kaiser Permanente, which has return rates of 80%. So when I started this program around the area of University of Pennsylvania, I gave them a challenge that we were going to beat that. And so I've gotten the help of many people to try to help me get that message out. And as I said earlier, we were working with a church, a Baptist church. And one of the things I learned was how much value and trust the leaders of that church command in their communities, in our communities, and that some patients are much more likely to do what their pastor and what their doctor tells them. And so I think it's incredibly powerful. That was an incredibly powerful realization to me as someone that wants to work with community leaders to really overcome the challenges of access to cancer screening tests. I think we underuse our community leaders, and perhaps as physicians and healthcare employees, challenges that have come our way related to colorectal cancer screening. So, so far, as I mentioned in my pilot, we gave out 150 tests. We got 73 back. So I'm getting close to the 50% mark, but I'm aiming to hopefully cross the 80% mark.
And that's actually a perfect transition to another question you received, which was, what logistical challenges did you have with the drive-by flu fit testing site, and how are they resolved?
That's a great question. Yes, we had, of course, lots of challenges, not to mention the weather, which was completely up to, chance. But one of the things that we had to do was obviously get PPE for all the people who were out there. We had to have traffic directors in this very large parking lot, directing traffic to either the flu only or the fit only or flu and fit. And we also had lots of challenges related to obviously building the infrastructure to knowing who's taking a fit test. And that way we could call those patients, get all the contact information, get 2 emergency contacts for every individual so that we knew who was taking one of these. And so we had to actually, one of the things we thought was we built a registration website, which asked if people wanted to have a fit test reserved, then they had to enter some information. That allowed us to also triage people who weren't right for a fit flu event. In other words, individuals who were outside of the range, age range, or individuals with symptoms. We needed to triage them right to colonoscopy. And so that was a REDCap database that we created, had an educational tool associated with it. And those are just to name a few. But thank you, great question.
Thank you. Our next question is about mailed fit programs. Specifically, this writer asks if someone on the panel can say more about what the literature is saying about mailed fit programs, specifically that someone mentioned some challenges and what those challenges might be.
And was the question to speak to the challenges? I'm sorry.
Yes.
Okay. So some of the challenges that you'll see both written in the literature and again, I think more in our own health center experience, we've had a couple pilots informally that probably aren't in a published way, have been in some of our rural communities where the post office, a couple things have happened. One is where the envelopes for returning the mailed fit are of an unusual size. And so in one community, we found that the post office just kind of stacked them up in a corner. And the way that we understood it was they were alerted to the fact that this was going to be sort of coming. So their approach had been, even despite some guidance of how to handle these mailings, had, again, grouped them and never mailed them on. Other scenarios have been where people didn't put, there's a significant amount of postage that's required on the envelope. So in some cases, there's been a good amount of postage, but not quite enough postage. And so I think the biggest issue, honestly, has been the lag time and or non-receipt. So patients who said they actually placed them in the post office, and in fact, they were never received back in. And so to some degree, we don't know all the reasons behind that. We only know that patient reports having mailed it and then it never being received. And so it's probably a combination of patient error, mail-in error, lost error, it's a combination of sources. But for all of those reasons, we opted not to, deploy the mailing strategy.
Yeah, and I think the cost has been prohibitive for many health systems. I know I do a lot of work in federally qualified health centers that, quite frankly, can't afford to do the postage in both directions for the mail ticket. So when you're mailing it, you want to make sure it gets completed, and we know that they don't always get returned.
Right.
This is a question that potentially Dr. Pachapin can comment on. The questioner asks, do we have the capacity to do optical colonoscopy on all the additional 45-year-old and older patients?
That's been debated. It's a great question. If we really followed the every 10 years and we gate it over 10 years so that not everyone comes the first year, the answer is possibly. I don't think that, first of all, we know not everybody's going to get a colonoscopy, and we know that one test is not going to solve the answer to get everybody screened, because not everybody's going to do just one test. But I do think for the people who would pick colonoscopy, as long as we don't do it all the first year it becomes available, it's doable. And again, as long as we offer other options as well. But that's being studied and being modeled. And Foley, you may have some modeling data on that I'm not even aware of, unpublished.
Yeah, no, and it actually matches exactly what you said, that if we use the resource appropriately, because as many people are aware, we have a problem with overuse and underuse with colonoscopy. So if we're able to balance that out, the challenge is that the overuse and underuse problems are in different populations, right? Again, back to what I think I was mentioning before, that if we're really going to take on this policy change, there needs to be systemic change in how we provide colorectal cancer screening as a service to make sure that it reaches the right populations at the right time.
And also interval, just post-polypectomy, the Multi-Society Task Force has changed the guidelines. If there's 1 or 2 small sub-centimeter polyps that are even adenomas, the interval now is 7 to 10 years. And actually that's on good data that we could wait 10 years even after a small adenoma is removed. People are still pushing for 3 years and 5 years. And so we have to make sure we utilize the resource exactly the way it should be utilized.
Absolutely. Another question that's actually a little bit on that topic about risk-based screening. And I think this question is for Dr. Guerra and her talk. And the question was, when you give the fits in the flu fit program, how do you screen people to make sure that they're actually in that average risk category and that fit is the appropriate screening test?
That's a great question, and it's absolutely critical to be able to do some sort of pre-registration assessment so that you know who really is appropriate for a flu fit campaign. And so we did. We conducted a questionnaire, which we built on REDCap. If anybody out there would like it, I'd be happy to share it with them. And essentially, it asks questions about family history and symptoms, prior colonoscopy results, as much as we could. And then what we did was, if it was not clear that this person really benefited from a FIT test, that it was clear that to us at that point that they needed a colonoscopy, we actually picked up the phone and just called them and clarified their family history or their symptoms. And so we told them that we would help navigate them to a colonoscopy if they were high risk. And so this was really for just the average risk patients. Thank you. Great question.
Thank you. And actually at this time, I want to thank all of our extraordinary panelists for joining us here this morning / afternoon, depending on where you're calling in from. This has been an extraordinary discussion. I want to remind our audience that they should please go to slido.com and enter the NCCRT 2020 after the session to provide your instant reaction and to give us any feedback that you have on our session today. Thank you all for joining. Have a wonderful rest of your day.
Thank you.
Thank
Thank
you.
you. Stay safe, everybody.
Yes.